people should be the most expertise anterior segment surgeons. I know that the anterior segment doesn't like that I say that, but it's true because this is what we face. Meiosis, pseudoexfoliation, lens luxation, angle occlusor, high myopia, lens-related glaucoma. So you will never have a normal cataract, except is because if a recommended patient, in my case, some VIP patients that comes and say, no, I want Dr. Schargel to have the surgery. This is what we usually have, and this is what we must clearly establish with our patient. There is two pathologies. The success rate of the cataract surgery nowadays is the highest one. So all the patients consider that after cataract surgery, they will have an outcome with a vision as similar as childhood, which is not true, but it improved quite a lot. We must clear to the patients that the glaucoma will not improve. You might get the same vision. The idea is to improve some of the quality of the vision, but I always prefer to lower the expectations of my patients, because I found out that when they found that there is better vision, then they are going to be even happier. So one thing that I first recommend in cataract patients is the Ashinoff-Shields technique, using different densities of viscoelastic in order to keep the pupil lower and protect the endothelium. A lot of our patients, especially with IOP spikes, will have problems in the endothelium, so the risk of decompensation later on is even higher. So always keep in mind that we need the viscoelastic to protect the endothelium, but also keep in mind that the viscoelastic will not cool the tip of the phycoemulsificator as fast as the water. So if you use a lot of viscoelastic, keep in consideration that it can warm it up and it can burn the incision. And then we have the meiosis, and you have different techniques for expanding. One of the most important things in cataract surgery is have a good vision. I'm a sailor, so I like to sail in the fog using compass and instrument, but here I will rather prefer or either stretch the pupil, which is not my preferred technique, because once you break the sphincter, the pupil will tend to get out of the incision. So you have to manage, okay, I'm going to stretch a little bit, enough to have those 5.5, 6 millimeters to see, or goes for another instrument. We have this one, only for the presentation is nice. I don't regularly use it. If I have to stretch, I prefer to use the Kuglen hooks, or then goes for the hooks. But there is one thing that is important regarding the hooks. When we talk about pseudoexfoliation, there is two different hooks. The first one is the Juan hook that is really for opening the pupil. We can use it to stabilize the back, but remember that it's not designed for that. The Macul hook is the one that has been designed to stabilize the back in pseudoexfoliation. I prefer to go for expansion rings. I feel more confident with the Malyugin. I can use it in the same incision. It's simple to use. There is two sizes. I prefer the 6.25 over the 7 millimeters for one particular reason. 6 millimeters is going to be enough for me for doing the capsulorhexis and most of the maneuvers, and it's softer. The 7 millimeters is very rigid, so using it inside, it's quite hard. The other thing is, at the moment of removing it, it's better to unlock, because if you only leave one or two unlock and the rest are attached to the iris, you can bite the iris and pull the iris with you. So it's small tips that we have to keep in mind. This was a study to compare the size of the pupil and and the loss of endothelial cells. It's always better to have a good view, because you can really work a little bit deeper and get away of the cornea. The O-ring was very nice in Europe, but here is very bulgy. I believe that the anatomy of the eyes and the anterior chamber here, and maybe even the cataracts that are thicker than the ones I used to deal in Europe, makes this ring not very suitable for my cases here. But it was very nice, it's very soft, easy to manipulate, similar to the Maljugin. There are many devices that you can use, but the advantage that I see in this is that you only have 2 incisions, while when you use the hooks, you need to make your 2 main paracentesis plus main incision and 4 or 5 additional incisions if you want to use the hooks. If you compare both of them, well, it seems that the Maljugin makes some more deformation of the iris sphincter that I don't think that really can be appreciated. What about the pseudoexfoliation? Well, pseudoexfoliation is a real amazing condition. We have a lot in Europe too. Probably the Vikings that migrate into the Mediterranean and let there some of the genes, but that's why in my region we also have pseudoexfoliation a lot. But what I never have seen was the lens dislocated and pushing and close angle related to pseudoexfoliation as I have seen here in the Middle East. So we must know that it's not only a glaucoma procedure. You can assist by doing a cataract surgery, you're going to lower the pressure in pseudoexfoliation, but if there is damage, I will suggest to go for something else, for a phaco-plus. We have to also think that not the instability of the lens only, but also the pupillary dilation will make the surgery more difficult, and even the long-term complications. So if you have a suspicion that that bag is not well established, well settled, it's better probably to fixate it with a capsular tension ring, because you can have late, like that case over there was a patient that just fell from the steps, but 1 step, not a real fell. And he has a dislocation of the lens, the back, and the capsular tension ring. So there are some signs that are clearly identified, talking about if that sonula is going to be stable or not. And one very, very clear in this region for me, if I have a narrow angle. If I have a narrow angle in a pseudoexfoliation case, I will always think that that sonula is not 100% stable. Recommendation regarding the phaco powers. I always lower all the parameters of my phaco machine, vacuum, IOP, and even the phaco power, except if the nucleus is very hard. Then you have to increase the power, but always keep the flows a little bit lower, because the aspiration will make turbulence inside of the back and can increase the risk of having a luxation. The capsular tension rings and the segments are very good. You can also use the segments and fixate it at the moment with the hooks, which helps you to stabilize the back. I think that all the maneuvers inside of that bag should be in a gentle way. The advantage of using a capsular tension ring is that will stabilize and push the bag, and then you can, in a way, work in safe. There is always the concern, when should I insert the capsular tension ring? The issue is, if you realize that there is an instability of the back, that will be the right moment. But if you have cortex or fragments of the nucleus, you will have an issue, because the volume, it will make it difficult to remove the cortex. What about the angle closer? Well, cataract surgery and the EAGLE study show us really good that the cataract surgery is a help for the stability of the angle, for the stability of the eye. This is an extreme case of an anophthalmic eye. You can see that after the surgery, the angle opened just a bit, but it helps in a way. What are the recommendations for cataract surgery or lens removal in non-ophthalmic or short eyes? Well, the most important thing I will suggest to keep the eye stable in all moments. So I prefer to work through paracentesis and only open the main incision for the phaco aspiration or the insertion of the lens. This is a young patient, an ophthalmic eye. This was a video that was accepted at the American Academy, not for other particular reason than I insert a 52 injectable IOL. It was a case that was refused by anterior segment because they say, well, we don't have a lens. So I talked to a medical tour and they say, no, we can customize a special lens. These cases are terrible if you let it aphakic. Young lady, the next day when I saw her, she was crying, and I was really shocked. I wasn't sure why she was crying, and then my assistant told me that she said that never saw in the way she was seeing that time. One eye is controlled only with the phacoemulsification or with the removal of the cataract. The other eye, 2 years later, needs a pole implant. This is the lens that it was inserted. And amazingly, the first eye went smooth. The second one was not that smooth. But as you see, the condition inside of the eye really improved by removing the lens. It's a matter of continent and space and location. We always have this issue, the choroidal effusion that is a risk. Choroidal effusion happens when you have a sudden decompression during the phacoemulsification. I don't usually do the sclerotomies except if I have a patient that I really consider that is in a high risk of having these choroidal effusions. Look for the anatomy of the angle. Sometimes we have lenses like this ICL first generation that is compressing the angle and then producing a glaucoma. So in these cases of damage in the angle, you not only have to remove the ICL, you have to remove probably the lens because it's also affected. As you can see, the difficulty here is to unlock the lens. This was the first generation ICL. Thanks God you probably will not see this anymore. We have now with the hole in the center. Myopia is the opposite thing. You have a very deep and you have to work really vertical. So also a good idea is to reduce the flow inside of the eye so you will have a better position of the lens. Some lens-related glaucomas are like the phacomorphic phacolytic. We have this beautiful case that I couldn't remove by phacoemulsification. It has to do an extracapsular cataract extraction, and you can see the fibrous tissue that is in the angle causing the increase of the pressure until being removed. And for those of the young generation, this is the Simcoe. We used to do all our cataracts with that. So evaluation of phacolytic glaucomas or lens-related glaucomas should be a full examination. Luxation of the lens according to traumas can produce close angle or related to lens, like in the anterior chamber. And when you have a phacolytic glaucoma, like in that picture, the most important thing, the risk is that the anterior capsule is not normal. Have you heard about the Argentinian flag, especially about the World Cup, right? Argentina won, so we are aware of the situation. So first thing, clears the anterior chamber, wash out, then make a small perforation in the anterior capsule and aspirate the liquefied proteins of the lens, and then you can probably proceed. Usually these are Morganian cataracts. It means it has a liquefied cortex and a very hard nucleus. Make an evaluation if that nucleus can be removed with phacoemulsification. I feel confident with extracapsular cataract. So if I think that I will need 100 power of phacoemulsification, I go on for an extra cap. Then you have subluxation that can also produce glaucoma. So all of this, the main surgery is anterior segment surgeries. Remember that some of our lens, 3 pieces lens, has an angulation. If you put it upside down, that lens is going to be all the time in the anterior chamber. So if that happens, think about the possibility of being upside down. When we deal with patients that have a previous trabeculectomy, the goal is also preserve that filtration surgery first. One of the issues is you can combine with a needling, but also the use of steroids post-op are very important in the cases that patient has a previous glaucoma surgery. I like to use acetazolamide if they have a previous glaucoma because the first 24 hours there are high risk of having spikes, and keep the steroids long time if they have a filtration surgery previously. So in summary, remember that when we are dealing with these cataracts and back view and back meiosis, it's important to have a perfect view of what you are doing. Try to keep that in all moments of the surgery. Keep in mind that we have to master the phacoemulsification techniques in order to combine with the glaucoma surgery. Thank you.
Our next talk will be with Dr. Abdullah bin Hamid, glaucoma with vitreoretinal surgeries.
Bismillah. Now we'll go to the last topic. For me, it's the glaucoma management after vitreoretinal surgery. The outlines for the lecture will be discuss the glaucoma after a scleral buckle, glaucoma after partial vitrectomy, glaucoma after intravitreal gas injections, then a glaucoma after silicone oil injection. So first topic will be the glaucoma after scleral buckle. We'll go through the incidence, risk factor, pathogenesis. We speak about the medical therapy and laser therapy and surgical management. So speaking about the incidence is the incidence of angle closure. Glaucoma after scleral buckling is reported range from 1.4 to 4.4. And the risk factor for that is that pre-existing narrow angles, use of an encircling band, and the placement of the encircling band anterior to the equator, and the high myopia patient, and older age, and the post-operative coleochoroidal detachment. And regarding the pathogenesis for that is that the scleral buckle will induce impaired venous drainage through the vortex vein, and this will lead to the congestion and the swelling of the ciliary body, and this will cause anterior rotation of the ciliary body and shift of the lens iris diaphragm forward. So about the medical therapy, in most cases, angle closure glaucoma after scleral buckling resolves spontaneously. But if medical therapy is needed, a cycloplegic need to be used to relax the ciliary muscle and shift the lens iris diaphragm posteriorly. Second is the topical corticosteroid, which is to reduce the inflammation and peripheral anticyanicia. Third is to use the aqueous suppressant to lower the IOP. And it's very important that we need to avoid the myotics because this will worsen the inflammation and exacerbate the angle narrowing. And regarding the laser therapy, iridotomy is usually VI is not needed, but iridoplasty may be used in some cases if the angle is narrow and to reopen it by using iridoplasty. Now we'll go to the last, which is surgical management of this condition. Usually, if the IOP is not controlled by medical, we'll go to the surgical management. And the surgical option we have, it could be filtering procedures, and it could be a cyclodestructive procedure, and it could be glaucoma drainage device. So speaking about the filtering procedures, and due to the presence of conjunctival scarring and recessions from retina surgery, which will make it very technically difficult and unlikely to succeed even with the adjunctive of antimetabolite. So this is not the best option in such condition. And speaking about the cyclodestructive, and due to the irreversible and frequently unpredictable IOP, and will make it less attractive option, especially in eye with good visual potential. Regarding the glaucoma drainage devices, usually this is the best option in using this after scleral buckling procedures. Going to the glaucoma after partial vitrectomy, we will go also to the incidence, risk factor, pathogenesis, medical therapy, and surgical management. So speaking about the incidence, it's reported that is ranging from 15 to 20%, and the risk factor for that is lens extractions, if it's combined with a scleral buckle, and if you use intraoperative endolaser. And the pathogenesis, actually, it's not well known what is why the cause of high IOP after partial vitrectomy, but there is some postulation that might be due to the diffusions of oxygen from the vitreous cavity to the anterior chamber, and this could cause alteration in the trabecular meshwork, and this is inducing oxidative stress, and this will affect on the outflow of the aqueous through the trabecular meshwork. So regarding the medical therapy, usually aqueous suppressant is the first line of a treatment in such condition. And for the surgical management, usually trabeculectomy is not the best option, especially with the previous retina surgery and the conj recessions, and they have high risk of failure. But it seems that the GDD, which is a glaucoma drainage devices, might be the best option after retina surgery. And regarding the glaucoma after intravitreal gas injection, we will go through as the same topics. The incidence in silicone study group found that 6 of the patients had an IOP greater than 30 using the SF6, and 18% and using the C3F8. So the risk factor using high concentration of the expansile gas and using the SC3F8 instead of SF6, older patient age, intraoperative use of photocoagulation, and the concurrent lensectomy and the placement of the scleral buckle, and also presence of fibrinous anterior chamber oxidate. And regarding the pathogenesis, is the injection of the gas, which will lead the displacement of the lens and iris diaphragm anteriorly, and this will lead to the angle closure either with or without a pupillary block. So the recommendation is the patient education is very important, and that asking the patient to face down to avoid any narrowing of the anterior chamber. And IOP should be assessed by using the Goldman, because the new magnetic tonometer and high displacement tonometer may significantly underestimate the IOP due to the compressibility of the intraocular gas. So for the medical therapy, the mild IOP elevation can occur during the early postoperative period and is usually respond to the aqueous suppressant. And, but if its IOP remain uncontrolled, aspiration of the intraocular gas may be performed to normalize the pressures. If there is a pupillary block, then the laser iridotomy is indicated in that situation. And about the surgical management, as we mentioned previously, retina surgery, after retina surgery, the conj will be already compromised and the high risk of scarring. So trabeculectomy or filtering procedure might be not the best option, but glaucoma drainage devices provide an important surgical option in that condition. So going to the last part of this lecture, which is a glaucoma after silicone oil injection. We speak about incidence, risk factor, pathogenesis, medical therapy, and laser therapy, and surgical management. So the incidence is ranging from 2.2 at 6 months to 56 at 8 months. But with the advancement on the retina surgery, the risk of glaucoma is becoming less and less. And they mentioned that also the use of the higher viscosity of silicone oil is resulting in fewer emulsified silicone oil to the anterior chamber, and this will induce a lower risk of glaucoma. So the risk factor for that, patient that they have a pre-existing glaucoma, the history of diabetes mellitus and aphakia, and the pathogenesis we divided into early postoperative and to the late onset. So for the early postoperative, we have pupillary block. It could be due to inflammation, could be due to pre-existing glaucoma, and it could be due to migration of the silicone oil to the anterior chamber. And for the late onset, it could be infiltration of the trabecular meshwork by the silicone bubble, chronic inflammation, synechial angle closure, and rubeosis iridis. For the laser, the pupillary block after silicone oil has been well described in aphakic eyes, and it's occur infrequently in phakic and pseudophakic because the intact lens capsule and the zinnules will prevent silicone oil to migrate to the anterior chamber. So the presence of zinnular weakness and may predispose this eye to silicone oil migration and the development of a pupillary block. So in that condition, the prophylactic inferior iridectomy should be performed in aphakic eye to prevent a pupillary block. So for the medical therapy, cycloplegia and corticosteroid and the aqueous suppressant, we are using that. And for the laser therapy, iridectomy inferiorly is important in case of aphakia. And for the cyclodestructive procedures, the transscleral photocoagulation have been used to treat glaucoma after silicone oil. And they successfully controlled IOP reported from 60 to 80%. But due to the multiple treatment may ultimately be required to achieve adequate pressure control. And the vision loss is not uncommon after cyclophotocoagulation. So for that reason, cyclodestructive are less desirable treatment option in patients with good visual potential. So this is one of the study that was done from King Khalid Eye Specialist Hospital, and where they compared the surgical outcome of glaucoma drainage devices comparing with the CBC in the patient that they developed glaucoma after silicone oil. And in this study, they report that the success rate for a glaucoma drainage device is reaching almost 90%, and it's reached 50% in the CBC group. And 5 eyes, they lost the vision due to the CBC, while 1 eye only lost the vision due to the tube. And they conclude that glaucoma drainage devices implantation may carry a high surgical success rate. However, CBC retain the advantage of being technically easier and repeatable. So what are the surgical management options for such eye that they have silicone oil? Either you go for silicone oil removal alone, or to go for concurrent silicone oil removal with the glaucoma surgery, or to go for glaucoma surgery alone. So the benefit of silicone oil removal in patients with elevated IOP, it's remained controversial. So one of the study, which is Jonas et al., they found that 90% of patients with secondary IOP increase after silicone oil, they had normalization of the IOP. While other study by Flaxel et al., they report that IOP is still elevated even after silicone oil removal. So even silicone oil removal itself, it can cause IOP elevation by splitting of the eye oil droplet in the anterior chamber and blocking the trabecular meshwork. This is a very nice study by Bodens et al., where they retrospectively reviewed the outcome of surgical intervention for secondary glaucoma. And the success was 69, 60, 56, 48 at 6, 12, 24, and 36 months. And what was the surgical management? It was consisted of silicone oil removal alone in 74 patients, and 11 of the 12 is failed due to uncontrolled IOP. And regarding the patient that they had glaucoma surgery with the silicone oil, they failed because of hypotony. And also those patients that they underwent glaucoma surgery only without silicone oil, they found that the failure is happening because of hypotony. So they conclude that silicone oil removal alone to control IOP are more likely to have persistent IOP elevation, while the concurrent silicone oil removal and the glaucoma surgery together is more likely to develop hypotony. So let's recap this. The surgical management of patient with silicone oil glaucoma should be modified according to the case that you have. So in case of patient with completely synically angle closure, we will not expect normalization of IOP with silicone oil removal alone. So glaucoma surgery might be, it's better to be either to be concurrent with the silicone oil removal or to be done without silicone oil according to the retina colleagues and they decided about the risk of redetachment. But if there is emulsified or non-emulsified oil, block the trabecular meshwork and the angle is open, might be it's reasonable to remove only the silicone oil without doing glaucoma surgery. And it's very important also to consent the patient to inform him that might be he needs in the future glaucoma surgery after silicone oil. So glaucoma devices offer a good surgical option in case of refractory glaucoma associated with silicone oil, but there is also a possibility of oil escape via the drainage tube. So in that situation, it's recommended to put the tube in the inferior quadrant to avoid the blocking of the tube by the silicone oil. Thank you very much.
So our next speaker will be Dr.Yousef AlZafiri. He is one of the pioneers of glaucoma and one of the first of glaucoma consultants here in Kuwait. And his topic will be about trabeculectomy tips and tricks. Please, Dr.
صباح الخير. شكرا دكتور عبد الله. بس بغيت أعرف الفرونت. This is okay. Okay. I agree with Dr. Konrad regarding, that our patients are more difficult here. I was really in Canada. When I came here, I was facing a lot of trouble, because doing surgery in European eyes is much easier, especially glaucoma surgery. Dealing with the iris, pigmentation, the SMA, everything is totally different. So now we adapted to this, and I think you did as well. Now, you know that the advances in glaucoma surgery, the mixed surgeries, Zen implant, preserved flow, all of them now are used. But still, the gold standard is trabeculectomy. So I'm going to talk about it. I'm going to talk about how to have successful surgery. First of all, you have to really make sure before you give retrobulbar or peribulbar block. Sometimes some people use subtenon. You have to know the anatomy of the patient eye. You have to see if the eyelids are tight, if the globe is small. Then you have to titrate your block accordingly to get less volume, because you don't want the eye very tight when you start your surgery. So try to minimize it and use the amount needed for each patient. So each patient has his own amount or volume of block. Another successful or key factor for success is exposure. As you know that for glaucoma surgery, we have to operate sometimes 8 millimeter or 9 millimeter posterior to the limbus. So you need to widen the eye as much as possible. Some people use wire speculum. I personally like to use adjustable Lieberman speculum, so I can adjust it according to the width I want it. The other thing is when you use attraction suture, you can use 7-0 vicryl or you can use 7-0 silk. When you pass through the cornea, you have to make sure that you're passing through the stroma. Never go so deep. And you can actually, before you start your pulling the eye downward, you have to really test your puncture with a wick sponge and to see if there is any leakage. Then you have to take your needle out and restart again. Sometimes you don't notice this unless you pull the eye down and start surgery, then your eye will be hypotenuse. Once you notice that, you have to stop, take the needle out, reform your anterior chamber with viscoelastic through paracentesis, and take another suture and another place. So this is very important and crucial for the success of the surgery. Okay. The other thing is we all, as a glaucoma surgeon, we have to respect the conjunctiva, especially for trabeculectomy. Using a special forceps or non-tooth forceps is a must. For me, I can use any of these three kinds of forceps. The main issue is not to pull the eye or the conjunctiva very hard and not to poke it, and you have to make sure you're not puncturing the conjunctiva. And this type of forceps that you can use for this surgery. If you don't have anything, you can use a tying forceps. Okay, so there is two incisions that we can approach in trabeculectomy, fornix-based and limbus-based. I usually like the limbus-based, but other surgeons like the fornix-based. Fornix-based have an advantage. The advantage is there is no leak at the site of the surgery because you're operating posteriorly, unless you have a buttonhole. The other advantage is very comfortable to the patient because there is no suture at the limbus. But difficulties require an assistant that can hold the conjunctiva for you while you're doing your trap. Limbal-based is easy. You can have a good exposure for your flap. It does not require an assistant, but it leaks. No matter how much you tighten your suture, sometimes you get a leak. And especially if the conjunctiva is very thin, then there's another problem. I'm going to skip this. Okay. Now, regarding mitomycin, after you're doing your conjunctiva, cutting conjunctiva, then you use mitomycin. Before, I used to use a sponge, Wexfield sponge, and to put it under the conjunctiva for like 3 minutes. The concentration is 0.4. But now I'm switching to injecting subconjunctivally. It's very important when you inject subconjunctival to titrate your mitomycin, not to use the same concentration. Is there a special formula that you follow and use it? I usually use 1:1 with lidocaine, 2%. And the advantage of the injection, first of all, you have to inject posterior, 9 millimeter. It's give you time. You can wait only 30 seconds, and less of waiting like 3 minutes for the sponges. There is no remnant of a sponge because it's been reported that sometimes when you pull your sponge, sometimes you mislodge it, especially if the patient is bleeding. You lose it sometimes. Fibers of filaments from it can create a problem in the future, which has been reported. So to me, I rather use subconjunctival mitomycin. I go back to the flap. It's very important to make your flap as big as possible and to make sure that the 1 millimeter or 2 millimeter near the limbus, don't cut it, leave it. This will help you to direct the flow posteriorly, and it's help you to make it diffuse bleb. This is the mitomycin, we talked about it. Now, before I used to use Kelly punch for sclerostomy. Now I'm using actually micro punch because you don't have to have a big sclerostomy. 0.5 millimeter of sclerostomy is very efficient to have a good trabeculectomy, especially you have less astigmatism, you have less aqueous flow, and you have more control of your flow when you're doing the trabeculectomy. The iris, I also, to do PI, you only need just to press posteriorly at the edge of your sclerostomy, and then the iris will come forward, then you can cut it with a scissor. But you have to make sure when you're cutting the iris, you have to look at the pupil, that the pupil is not dragged. Sometimes accidentally you can cut the sphincters, so you have to really make sure that you are pulling in a small amount of iris and cut it safely. At the end, closure is very important. When you're doing fornix base, I usually close 2 layers, tenon first and then conjunctiva. But for the limbal base, you have to do either matrix suture or you can do a burst sling suture at the edges, and you can tighten it as much as you can. But you might have also a leak doing also this. So at the end, it's very important to know your anatomy before you do any glaucoma surgery. And practice makes perfect. Thank you.
So I agree with Dr. Yousef AlZafiri. Old is gold. No matter how much we advance, sometimes you just have to go back to your standard, and our gold standard is trabeculectomy. So thank you, Dr. Yousef. The next talk will be automated static perimetry and the importance of glaucoma progression analysis by Dr. Nasser Aljumaian.
Well, this is the advantage of doing your fellowship in the neighborhood. Okay. All right. So the main topic is the glaucoma progression analysis. But in order to explain that, we have to explain the automated static perimetry by Humphrey. So, as a glaucoma specialist, I always prefer the 24-2 CETA standard over the CETA fast. And here you'll go in battle with the technician. He wants to go finish early with the CETA fast, and you want better representation of your patient damaged by the CETA standard. So the 24-2 is examining like 54 locations in the field. And those are also the same location with the 30-2 except for the outermost locations. And here we can see, those with the half blue, half orange are the 24-2 with the 30-2. But the one in the orange color are the 30-2. So in glaucoma, you just need this field only to represent or to have an idea about the glaucomatous damage that you have. So in terms of timing, for single eye, the 30-2 CETA standard that take about like 5.5 minutes to 10 minutes per eye. That CETA standard fast and the CETA standard 24-2 is 3 to 7 minutes. That CETA fast 24-2 take from 2 to 5 minutes. So what he's saving only is like 2 to 3 minutes per eye, which is not justified. So if we look at the single field analysis, what is representing? First, as Dr. Abdullah had said, you always need to identify your patient. Make sure that you are looking at the test of your own patient. Don't mix it with other patient, and you can create lots of confusion by that. Then I would look at the test strategy. I will make sure that I'm having the same test strategy that I asked for, which is the CETA standard. Then I look at the test duration, and I have a good idea about how the patient is tolerating the test. Is he bored? Is he doing well with the test? And then you go from that looking at your grayscale, and you have the grayscale map, then you have the threshold values, and you have your total deviation maps on the left and the pattern deviation map on the right, and you have your glaucoma hemifield test value with the visual field indices. And I'll talk about this in a bit of details now. So the grayscale, what is represented? Just represent intuitive way of presenting raw decibel that was not compared to the normal age group and not analyzed till now. So its importance is the least in the visual field. So we go to the total deviation maps, and you have the numerical and the probability plot maps. The numerical decibel deviation from age-corrected normal sensitive. That would mean that this patient, you see how much is deviate from the same age group. Does he have the same sensitivity or is it less? And the numerical value will shown in terms of it's 0, that means that there is no change in his sensitivity, or it could be -1 until minus infinity. Okay. More importantly, the total deviation probability map, which highlight the deviation that fall outside the statistical range of normal sensitivity. Okay. So this is what I'm talking about. So the better the pattern deviation maps. The pattern deviation maps highlight localized loss after first correcting for any overall changes in the height of field of vision. That means when you have some sort of obesity obscuring all the field of vision, it should be corrected by the machine. Then it will search for the localized area of defects, and it will be represented by the pattern deviation map. And you have your numerical and probability plot with these. The glaucoma hemifield test, what does it tell you is compares the pattern in 5 different areas in the upper hemifield with the same comparable areas in the lower hemifield, and tells you if there is any change which goes within normal limits or outside the normal limits. And this can give you a simple language test report for any non-ophthalmic specialized personnel. The visual field indices, which are the mean deviation and visual field index and pattern standard deviation, these are indices that is needed for the follow-up rather than initial test. The mean deviation is just a weight average of the value represented by the numerical total deviation map, which will give you in a single figure, while the visual field index is representation of the central visual field, which can represent in simple way the ganglion cell population in the macula. The normal vision usually associated with 100% VFI, and with the blindness, the VFI reached 0. The pattern standard deviation summarized the localized loss in a single index while ignoring the generalized depression. So the pattern standard deviation is low for normal fields and uniformly depressed fields, and for blind fields also. And it's highest in the moderate to advanced loss. Now we'll talk about the reliability indices, and you have 3 of them. We have the false negative, and we have the false positive, and the fixation loss. I will talk about these in order. The false positive response, what does it mean? It means that the patient is like habit trigger. He's responding whether he saw a stimulus or he didn't see. And this also can includes his pressing the response during the stimulus or immediately after seeing it in a quicker way than he used to do. So false positive is one of the most important reliability. It's actually the most important one among the 3s. And it's acceptable up to 15%. Above that, the test should be rejected and repeated. False negative. False negative error, what does it mean is that the patient was not responding to a brighter stimulus on the same area that he responded before. So unfortunately for a glaucoma patient, this phenomena is normal because in a glaucoma patient, they have some sort of saturation in the macula, in the retina. When they have a stimulus, they usually don't respond for a long period of time in this area until they recovered from the saturation from the bright light. So you cannot blame the patient for that. He has a high false negative. And it's acceptable up to 30%. Okay, so this is the false negative. Fixation loss. Fixation loss, the machine is determining where is the blind spot in the field, and is determined that this spotlight is the disc light is blind spot shouldn't the patient respond when he got a stimulus in it. So once the patient give a response to a stimulus in this area, he considered to be fixating loss. He's losing his fixation. So this is in summary about the visual field. And now I'll talk about the glaucoma progression analysis. Why we do need glaucoma progression analysis? Shouldn't the visual field, the single field test is alone by itself enough? Well, we'll talk about this now. What it uses the theta and the beta deviation to identify glaucoma specific progression. It was enrolled glaucoma patient in 16 sentinel trial to quantify the variability. The glaucoma progression analysis flags change at point exceeding expected patient variability. And it employs strict progression criteria by the early management glaucoma trial study. The mean deviation slope plot helps also to identify the high-risk patients. And this is the reason that why we need the glaucoma progression analysis. If you see at this graph that you will see the patient with the highest variability in the visual field, that its visual field each time it changes, are the people with the deep defects that are, in simple term, are the high advanced glaucoma patient. While you'll see in the blue here, in the first, you see the normal people, the normal population, their visual field doesn't vary much. So what does it tell us, the glaucoma progression analysis? You need at least 3 tests to establish it. You need 2 baseline visual field and 1 follow-up. Each follow-up is compared to average threshold of 2 baseline exam in each visit. Additional follow-up compared both baseline to the 2 most recent follow-ups. And the symbol goes like that. Hollow triangle that will tell you there is a progression at 95% significance level. And the triangle will get half darkened when there's consecutive exam showing the same progression. And for the third consecutive exam, it will be darkened. So 3 triangles, the machine will tell you there is possible progression. If you have 3 darkened triangles, the machine will tell you likely progression. And we'll talk about this now in a bit of details. So, what about the patient that already had their visual field and you didn't set the progression, the glaucoma progression analysis for them? You can still do retrospective analysis of those tests if you have them. So this is an example. This is a patient who had 5 exams in the past. So there's yours 2 baseline here, and then you have the first follow-up and the left here up. So the machine will now recognize the area of progression, and we will keep them in hollow triangles. For the consecutive exam, it will give you half darkened triangle, and it will tell you there is possible progression. It will alert you. For the consecutive exam, if it still persists, it will tell you likely progression. So this is the printout of the GBA. So the first, you will see your grayscale map. Near to it is the pattern deviation map. And near to it is the deviation from the baseline. This is not the total deviation. This is the deviation from his own previous values. So the patient was like measured like -1, and now he's like -3. So his deviation from his own values, the previous values. And still, the glaucoma progression analysis can alert you about the low test reliability. Still, it's going to alert you about these, and you still have your own, his own indices, the reliability indices. So the printout is like this with the single field analysis. So you will have your usual 6 maps, and you will have near to it is the glaucoma progression analysis or event analysis with its changes, and will tell you that there is likely progression or possible progression. And this is example to tell you about these triangles. Here you see them in hollow triangles, and repeatable change will be in half darkened, and if it continues to be there, it will be darkened all the way, and the alert will be possible with this half darkened triangle, and likely progression if it's totally darked. Okay. This is a case of unilateral progression. You can see this is the left eye of the patient, and this is the right eye, and we can see there is some changes in the right eye, which is nasal step. And for the follow-ups, we noticed that the patient changes or progressed from the progression analysis. Tell us that there's first possible progression, and continues, it will tell you the likely progression. So the summary, it will give you like this printout, which contains, in addition to the event analysis, what we'll talk about is the triangles. It will give us how the visual field index behaves during those tests. You can see here's the slope goes down with the visual field index, and also it can predict in the coming years how the patient behave, or the VFI will behave in the coming years. So in 5 years, the patient will be from like here, it's like 75%, it will reach like 72 or 76 or 67%. So it will tell you that your management is still not enough. You have to do something else. You need to change your medication, or you need to introduce surgery for this patient. And this is what I told you about, in addition to the event analysis that is comparing every subsequent test against the baseline. The trend analysis is a linear progression to assess the rate of and significance at which the measurement is changing over time. This is another maybe clearer picture of the things that you can see here. The patient age with the visual field index, and with the same management, it will tell you that your visual field index is going down. So you can review yourself about how controlled is the patient, and you can interfere with different management. And thank you very much.
Thank you, Dr. Nasser, for the extensive visual field presentation. Can we have, please, the speakers come up to the podium for the panel discussion? So, as we started with the first session, I thought we had a hurricane, so. The first question goes to the speakers, if they have any questions for each other.
Well, first the audience, then we'll come.
And actually, I have a question regarding with Dr. Abdullah regarding buccal and valve.
Yeah.
It's most difficult, surgery, especially if the buccal is placed anteriorly. If you don't have enough space to implant your valve,
Exactly.
what to do in this case?
Actually, I was planning to review the literature about what is the best way to approach a glaucoma drainage device in patient that he had sclerobuccal. But for the sake of time, I didn't present it, but there is some study that they report either just to put the tube without the plate among the fibrous capsule that have been formed on the sclerobuccal, and they suture it back. So it's like an encapsulation. You use it as a reservoir for the aqueous humor. This is one of the studies. Another, they report that might be the tube. You can put it either underneath it or just above it, but you would use the thin one, not the Ahmad implant will be thicker. They use the bare belt and to put it. Third, if it's anteriorly, can be given, you put it posterior to the sclerobuccal, and the tube will be passed underneath it. This is the most difficult. I know that's the tube in the sclerobuccal.
The reason I ask you this because I have experience with this. I met once an Indian glaucoma surgeon, and they use a very nice valve in India. Yeah. It's called Mehta valve. It's shunt, It's valve shunt. And it's very malleable that you can trim it the way you want it, and you keep the valve with the tube. I did actually 3 cases.
Okay.
And it's, the oldest one is about 12 years old.
Okay.
Surgery, and it's very nice. You trim the valve, you make it even like 2 millimeter, 3 millimeter, and you attach it to the buccal. You just, undermine the buccal and then suture the valve, and then put the tube inside.
So underneath the buccal will be...
No. Just at the side, because there is actually the valve, what's left of the valve is very small.
Yeah.
And it's act like it's a regular valve, and you can use the buccal as a reservoir.
Yeah. But to be honest, I don't have experience with this.
Yeah.
Might be...
I can give you the name of this special valve that you can use in the future.
Exactly. Interesting. Mm-hmm. You have experience with Dr. Konrad, do you have experience with that? The tube on the...
with the sclerobuckler. I was listening to that. We used long time ago. I don't know if you have
the Shocket.
The Shocket.
Yeah, the Shocket.
Yes.
The Crawford tube.
The Shocket was a good solution in a way that is using a elastic tube and trying to use the capsule that is formed around the sclerobuckler. It's a non-valve, and the outcomes were not as great. So in my experience, sometimes you can cut that line of the sclerobuckler to create a space. What I found is that sometimes we put the sclerobuckler too anterior, so you still having some space, and I'm more happy now with the new tubes that are soft. The eye plate without the eye watch, it's really soft.
Soft tubes, yeah. That's the key.
Because I don't feel good to put an Ahmed, which is a rigid valve, and it goes too posterior, so the tip can hit the optic nerve.
Any questions from the audience?
Get the chance, we're gonna leave after this.
My question is directed to Dr. Nasser about the visual field. The normative data, which is stored in the computer.
Excuse me, I can't hear you very well. Can you read?
The normative data, which is stored in the computer,
data.
when it's compared with the patient's data, I'm just wondering about the age group that is stored in the computer.
The same age group.
I'm
the
sorry?
same age group.
Yes, but what is the range that has been stored in the computer? Like the youngest age that
As I mentioned, it's CETA standard, that stands for Swedish interactive algorithm. So this data was collected by the Swedish Society of Glaucoma that established this system. So I don't know about this, but this is what the machine tells you. For patient age like 65, he will be compared to the same age group. If he goes within the normal range of those population, the machine will give you 0. There is no change. For the total deviation I'm talking about. But if he's less sensitive, will be, like I said, he will be -2. But he means he's less than the normal population by 2. Sometimes you'll see it in positive. That means that this patient is more sensitive than the normal population. It gives you like +1 or +2 or +3. Do you understand me?
Sir, I had a patient who was 12 years old. And so I was just wondering, does the computer have that age group?
7, you mean what? 7 years old?
No, 12.
12 years old?
So, no, yes.
It will not be in the algorithm.
It won't be in the...
Okay.
No, it's
So
too young.
where does it start from?
Usually I'm not exactly about the numbers, but I think the youngest were 18.
18, all right. That's what I wanted to know.
We were facing the same issue with the GDX. When we start with the GDX, we faced 2 problems. You know, the GDX was the polarimetry that you mentioned as the OCT. And the database, it's usually for older patients. And the other thing that these were designed, the CETA was designed in Sweden, but the GDX was designed in the States. And they include, for example, race. And the race, we thought that we were Hispanic in Spain when we were using it. And for them, we were Caucasians. So it was also a variability on the thickness regarding the Hispanics were Mexicans and Latin Americans. So sometimes with this database, we have to be careful, especially if you get out of the range, too young, too old. That's an issue. But for visual fields in younger patients, if they are good and the false positive, false negative, fixation loss index, all the quality index are okay, do a couple of them and use these 2-3 tests as the baseline for that particular case. That will be the best.
Okay, thank you very much. Thank you.
Any other questions? Any questions from Dr. Yousef, Dr. Nasser, Dr. Abdullah?
About ball implant. I would like to go back to it again. So, as we all know, it's the breakthrough in this device is it's the small tube, but still it have this massive blade. So I faced a lot of cases that I have difficulty placing Ahmed in those patients. So I was putting in my mind, what if the patient is having shallow orbit, like a child? Do you still can do Paul with them?
That's with Paul we are learning.
Yeah.
And what we are getting into our experience with this kind of devices is our previous experience with other devices. What I meant is, you mentioned perfectly in your lecture, you have a huge monster like Varbel or Adi. That is a huge monster. Sometimes when we are doing the surgery and we have a medical student and we make the nice dissection, my fellows are going to introduce an Adi tube. I look at the student and I say, now comes the target. You're going to see how a huge piece of plastic, we put it inside of the orbit. This is the reality. So what we face with the pole is that it's so soft, the material. It's for me, the best tubes right now are the pole regarding the materials and the eye plate. I don't know if you had the chance to try the eye plate. They are so soft, you can fold it and put it in a micro incision for tubes. And then it opens like this, and as you well explained, it's designed in a way that you pull it up and it mainly goes right under the muscles. You can tell that I'm a fan of these tubes, right? Well, anyways, this tube has these properties, are very thin, so in a challenge cases, you can use it. In kids, what I do is an axial length, because, for example, most of these babies with glaucoma that have a couple of surgeries that fails, has an axial lens that is about adult size already, 24 millimeters. You have to keep in mind that even if they have 24 millimeters, they have a very elastic and thin sclera. So the fixation is more an issue than the introduction of the pole implant, in the experience that I have. It's not very large, but I have right now 6 kids with age under 3 years that went good. More challenge than that one was an anophthalmic eye, 16 millimeters of axial length. Mm-hmm. And that was more challenge because my concern was till where it's gonna go, the posterior part. You showed perfectly. The axial, the length of that tube is 16 millimeters. So I was calculating it's gonna be around the optic nerve entrance. But it's managed very good. So in kids, so far, if you believe that there is space, it will go easier, and I think it will work better than the pediatric Ahmed tube. I'm not very fan of the Ahmed. I think that here in this region, in my hands, fails a lot in my hands. That doesn't mean that it fails.
No, it fails with us also.
Eh?
It fails with everyone.
Oh, now I'm going back feeling better.
Yeah. That's why I did like 4 patients, half Ahmed, half Ball, and I was comparing. Still, I'm not didn't through my study till now. I'm still collecting patients, but I noticed there is superiority in Ball. Interesting. Yeah, as it's normal that you start some sort of equisuppressant with Ahmed within like 1 month. That Correct. Goes from hypotensive phase to the hypersensitive phase. You have to go with some sort like Cozopt or Alphagan or whatever.
Yes.
You have to go with that, otherwise you are seeking failure with Ahmed. What I mean, till this moment, I removed most of the ripcord of my patients, except one is still maintained at 9 after like 4 months now. Mm-hmm. So I don't need to remove the ripcord. This
Absolutely.
For what reason I'm going to remove it? It's functioning well compared to Ahmed that you need to add.
Keep it if it's functioning well. You don't need to remove.
Yeah.
I removed one ripcord in a Varbel valve implanted by Randy Craven 8 years back. 8 years back. So I prefer the non-valve. It's true that you have to know how to manage. You have to put the ripcord, sometimes do a ligature, give sometimes fenestration. So, but among the new generation of non-valve tubes, I think that there is a lot of things coming, and that is promising. So now, one question. How many of here, we're still doing trabeculectomy? Can we raise the hands? Good, good. Yes, but because, you know, I think that the tips you gave are extremely important. As you said, we have a lot of new things and we all want to try. But trabeculectomy is still being the gold standard that we can use in most of the cases. And you really present the steps very, very nice. I think that it's also very important, the post-op of these surgeries. You know, some of these patients go away, and then when they come back, it's like 6 months, and you say, well, we missed a lot of opportunities in the control of the trabeculectomies.
It's very, just wanted to add, also very important, especially for our patient or valve patient who comes to your clinic. Blepharitis is very dangerous for us, especially for tube exposure. So we really have to treat it very well. If you see a patient who had a tube and there is blepharitis, then treat this patient aggressively. Because, you know, sometimes I see a lot of patients with blepharitis who end up with tube exposure faster than other people. So I really emphasize importantly on treating blepharitis, especially in our region.
Yes.
A lot of people have it.
Yeah, it's funny because we said, oh, we're going to schedule a trabeculectomy patient, and in Europe we say, we're going to stop all the medication, put it in steroids for 2 months, 8 weeks, and now that I'm here, I say, I don't feel brave enough to tell a patient in such a state, stop all the meds, I'm going to put you on steroid for 8 weeks and then do a trabeculectomy. I don't feel like doing that. I'm adjusting my techniques to the environment that I feel here, which I appreciate. It's a very nice teaching tool.
You're doing a good job so far.
I have a question to all of the panel, anyone who can answer me. Sometimes some patients have such a poor exposure that it's much easier to put the tube than to needle it or revise it. You understand what I mean? Where you can expose the conjunctiva superiorly, just enough 8 millimeters just to put the anchoring sutures for the tube. You cannot see the body of the tube. So when it comes to revision, where you want to remove the fibrosis, what's your advice on such cases where you cannot go beyond, you cannot see the body of the tube itself anymore, and you cannot open the conch on top of it to remove the fibrosis? What are your advice?
If I understood correctly, you are not able to see the posterior part of the tube, like the plate?
You can only see the
Entrance.
The entrance only.
You mean
The junction of the tube and the reservoir. You cannot see the rest of the...
Retracted, you mean?
Retracted.
Yeah, no, it's not retracted.
It's not visible?
It's when you operate, you realize you have such limited exposure. You are still able to get away with putting the tube because you are just securing the... But then when it comes to removing the fibrosis, most of the fibrosis on the reservoir, I mean, you can de-roof the fibrosis on top of the tube.
Okay.
But that's not the best of approach. What is your advice on these cases?
Is it functioning tube? Or it's not
Well,
functioning?
no, obviously, with the pressure is going up. And
Yeah,
the
pressure
patients-
going, but it's still sometimes functioning tube, but
Yeah,
there is
I
other
did
factors.
several needling, and some of these needlings I'm going blindly because of the limited exposure. I'm going behind the lid and trying to.
I tried, a couple of times, repairing or reforming or, needling sometimes, I find it's not successful.
Yeah,
I
yes.
really do find it not successful.
I did 3 needlings, and it works for a few days or a few weeks,
Yeah,
and then
it goes
it
back
fibros
again.
again. So it's time for revision. The thing is, I don't have access to the. So
I found here in my Ahmed tube that, I really try to reach the plate, and what I like to do is a large incision, an open window, and what I found is usually a large, thick capsule around the plate. So I try to cut a window that sometimes I have to cut it with the NVR,
yes.
and then wait and see if I prefer to do that without any decompression of the anterior chamber because I want to see the aqueous coming through the valve.
Absolutely.
What I found is that very often there is no aqueous coming through that even large window, even when you have the access. And then I get the McPherson forceps, and I try to go into the valve mechanism. And I have a video, a couple of videos, very nice, in which there is a fibrous tissue that grows into the valve.
Okay.
So you grab it, you pull it, and then you have the outflow coming. And for myself, I said, well, it used to be a valve, now it's a tube, because I'm sure that I break the silicone mechanism.
Yes.
For those that, what we're talking is the Ahmed has a Venturi system with 2 laminas of silicone. So if, in theory, if the pressure inside of the eye is over 16, those laminas should open and let the aqueous go out. And if the pressure goes below 16, the laminas will close. What I saw is that restrict the flow, but also when there is a restriction of flow, allows the fibrous tissue to grow into it. And when you grab it and you pull it, you break it, you remove the membrane, but you also membrane, the silicone is gone. And then I just close the conch on that. So far, even doing such a massive revision, in around 18 months, those tubes stopped working. This is what I have.
Yeah, this is one of the problems with Ahmed valve. It's the encapsulation, which is the formation of thick tenon capsule around Ahmed, and this is more prevalent in younger patients. And first time I saw it with Dr. Ibrahim Jadan, he's going crazy. He's going through the sclera. I thought this was a sclera, honestly. He was cutting. I thought very thick.
Yes.
Is this tenon? So when he opens it, I saw Ahmed valve underneath it to say, wow. And the same thing Dr. Konrad said, there is some sort of strand going through it, and we pull it, then we see a gush coming out of Ahmed. And the same thing was done is to just remove as much of the encapsulation above it. And this is the advantage of barbell over Ahmed, that you have less encapsulation because the blade goes underneath the muscles, preventing the capsule to be formed completely around the tube.
Sorry, just to add to mine, it's the only reason why I use mitomycin in tubes. Once I open that, I put the sponges of mitomycin as far back as I can, and I wash a little bit, and then I close it.
This is for revision, not for...
For revision. I never use mitomycin in the first implantation of a tube, but I only use mitomycin in tubes when I do a revision.
So back to my case, my tough case, would you recommend that I will open a window in the fibrosis? There's fluid. When I did needling, fluid was coming nicely. So it is not closed at the level of the reservoir. The reservoir is working well.
You do the needlings with mitomycin or without mitomycin?
No, I tried once with 5FU and I tried once with the Kinecort.
Okay.
It worked very short time and didn't work. So would you recommend that I make this opening, this window on the fibrosed capsule on the tube area? Do you think this is...
A little bit behind the tube area, like over the valve?
Close to the junction?
Yes.
Okay.
I probably will do, because you have tried everything. You have tried the simple. I like that procedure, you know. You start with a needling, second needling, but if it works for a short period, maybe there is something there that is causing the problem. So I would like to take a look.
Of course, there's one radical solution, which is cut the upper lid in half, do your procedure, and then resuture it. But obviously, this is very...
The other thing, very hard work is replace the tube.
I'm worried about, plate exposure in these cases.
Exactly.
Very scary.
So when I do this window, you might risk the exposure.
So I'd rather do another valve to the side.
That's another option, yes.
Yeah, because the other option is just to remove everything and start something different.
If it's functioning, I think sometimes the valve is functioning.
Forget about that side.
Forget about it, search for another place.
How old is the patient? That is also important.
He's in his 60s.
60s?
Yes.
That's very young.
And
it's my age.
Superior temporal, superior nasal is valid?
Think about...
I use his superior temporal.
Yeah, but the superior nasal is...
Yeah. Well, obviously the exposure is going to be always a challenge.
But if I have superior temporal, I'll go to superior nasal.
Okay.
I want to play with it. Go to another quadrant and place
different,
a new tube.
Okay. I'm happy that I'm not the only baffled person here.
Well, I'd like to thank all the speakers and all the attendees for being here today. I think we've passed our assigned time. So again, let's give the speakers a great applause. And let's give ourselves an applause. So you love the speakers more than yourselves? Thank you all for being here. For those who have the deep sclerectomy workshop, hands-on, we're heading now to Hall C on Mizanin. For those that don't have workshop, it'll be lunch and prayer time at around 12:20, also in Mizanin. Thank you all.